Welcome, curious learners, to the deep dive. Let's begin today with something so fundamental, so automatic, you've probably done it thousands of times already today without even thinking. Breathing. Air in, air out. Sounds simple, right? But underneath that, well, simplicity lies one of the body's most intricate systems. Today, we're taking a deep dive into the incredible structure and function of the pulmonary system. Our mission here really is to navigate this complex system together. We'll guide you step by step through the major concepts, the mechanisms, maybe a few clinical examples too. We're drawing from a fantastic chapter in Understanding Pathophysiology, 7th edition. The goal, a clear understanding without getting, totally bogged down in jargon. We'll explore the 3 primary steps. Getting air in and out, that's ventilation, how gases swap places, diffusion, and how blood flows through the lungs, perfusion.
Exactly. And, for anyone curious about how their body works, or especially if you're studying health sciences, getting these basics down is it's crucial. Think of it like the operating manual for this nonstop function. We'll show you how all the pieces fit together to keep you supplied with oxygen and get rid of that carbon dioxide.
Okay, let's unpack this then. Let's start with the foundational structures, the grand design.
Yeah.
What are the key players here? Well, you've got your 2 lungs, obviously. Then the airways, upper and lower pathways for the air. Their blood vessels, the diaphragm muscle underneath, and the chest wall protecting everything. And the lungs aren't just bags, are they? The right lung has 3 sections, lobes. The left has 2, and they break down even smaller. And right in the middle, between the lungs, that's space.
The mediastinum, where the heart and the big vessels sit. Right. But what's really clever is the system's built-in defense. I mean, before air even gets deep, there's this multi-layered security. For instance, the lining in your upper airway. It's like a personal climate control, warms and humidifies the air. And your nasal hairs, the turbinates. They're the first filters, trapping bigger stuff.
Okay.
Then deeper down in the trachea, the bronchi, you've got this mucus layer and tiny hairs, cilia, constantly sweeping particles up, like microscopic escalators, basically.
Escalators. I like that.
Yeah, towards your throat, so you can swallow or cough them out. Plus, irritant receptors trigger sneezes and cough, forceful eviction,
Right, get out.
And if anything does get way down into the alveoli, these special immune cells, alveolar macrophages, waiting. They engulf invaders, release signals. They're the cleanup crew. It's an amazing defense, working 24/7.
That's incredible. A whole defense force just for breathing. Okay, so keeping those defenses in mind, let's trace the air path, the conducting airways. This is just the route in and out, right? No gas exchange here yet. Starts with the upper airway nose, throat. Crucial for that warming, humidifying, filtering, which is why mouth breathing isn't quite as good, bypasses the prep work.
Exactly. It misses that first stage.
Then we hit the larynx, the voice box, that cartilage structure connecting upper and lower airways. It's got vocal cords, sure, but it also keeps the airway open during breathing and stops food going down the wrong way. Super important.
Absolutely vital.
From there, down the trachea, that tube with the U-shaped cartilage supports, which then splits. 2 main bronchi.
At the carina,
Right, the carina. And those bronchies dive into each lung and just keep branching. Smaller and smaller, like a tree. The lining gets thinner as you go deeper.
Until you reach the actual gas exchange sites. And here's where it gets really interesting. The gas exchange airways. These tiniest conducting airways end in respiratory bronchioles, alveolar ducts, and then the alveoli themselves. That whole cluster, that's the sinus. This is where the magic happens.
The alveoli are those tiny, delicate air sacs.
That's right. Primary units for O2 coming in, CO2 going out. And get this, you have about 300 million of them by adulthood.
Wow, 300 million.
Yeah. And they're connected, too, by little pores, the pores of cone. Lets air distribute evenly between them. Now, inside these alveoli, you've got 2 main cell types. Type I are for structure, making those super thin walls. But type 2 cells, they're the stars. They secrete surfactant.
Surfactant. Okay, what's that do?
Think of it like a detergent lining the inside. It's absolutely crucial because it lowers surface tension, stops the alveoli from collapsing completely when you breathe out, and keeps them from filling with fluid.
So without it, breathing would be way harder.
Exhausting.
Yeah.
Like trying to inflate sticky balloons with every breath. Plus, it has these colectin proteins that help fight off germs. Another defense layer.
Got it. Okay, air pathways covered. Let's switch to the blood side. Pulmonary and bronchial circulation. How does blood flow through the lungs? What's its job besides just grabbing oxygen? Well, the pulmonary circulation does more than gas exchange. It feeds the lung tissues, acts as a sort of backup reservoir for the heart, and filters out little clots or debris. And what's striking is the pressure, right? It's much lower than in the rest of the body. makes it super efficient, low effort. Only about a third of the vessels are even being used at any one time.
Exactly. And that leads us to the alveolo-capillary membrane. This is incredible. It's the shared wall between the capillary and the alveolus, and it is so thin.
Just a couple of layers.
Barely. Minimizes the distance gases have to travel. Its thinness is key. If anything thickens this membrane disease, inflammation gas exchange gets impaired. Badly. It's designed for speed and efficiency. Now, separate from that, you also have the bronchial circulation. This is actually part of the body's main systemic circulation. Its job: moisten air, feed the airways themselves, lymph nodes, the pleura.
And not gas exchange.
Correct. No gas exchange there. And then you've got lymphatic capillaries, too, draining fluid, removing those macrophages we mentioned, keeping things clean.
Okay, intricate plumbing indeed. So how is this blood flow controlled? Control of the pulmonary circulation. The smooth muscles in the artery walls, right? They contract or relax.
Changes the diameter, alters flow. But here's the fascinating part. The most important trigger for constriction, for tightening those vessels. Low oxygen in the alveoli. It's called hypoxic pulmonary vasoconstriction. Basically, the lungs' smart traffic controller. If an area isn't getting good oxygen, the blood vessels there squeeze down.
Rerouting the blood.
Exactly. Sends the blood to areas that are well ventilated. It's like a built-in GPS, constantly optimizing blood flow for the best gas pickup.
That's brilliant, but what if that low oxygen state lasts a long time?
Good point. If it becomes chronic, that vasoconstriction can lead to permanent changes. Pulmonary artery, hypertension, and eventually the right side of the heart can fail. That's core pulmonale.
Right. Other things can cause constriction too, like high acid levels in the blood.
Yep, acidemia also constricts, but like hypoxia, it's often reversible if you fix the underlying problem.
Okay. Let's move outward now to the chest wall and pleura, the protective shell and the movement mechanics. So the chest wall skin, ribs, the muscles between them shields the lungs. These muscles, plus the diaphragm, do the work of breathing, and the space inside is the thoracic cavity.
Right, and wrapped around the lungs, you have these two layers, the pleurae. The visceral pleura sticks right to the lung surface.
And the parietal pleura lines the chest cavity.
Exactly. And between them, the pleural space, it's tiny. Just a thin film of fluid, like lubricant, lets the lungs slide smoothly. And crucially, the pressure in this space is normally negative, subatmospheric, like a gentle suction helping keep the lungs pulled outwards, expanded.
Okay, so bringing it all together, function of the pulmonary system. It really boils down to those three main jobs again, doesn't it?
It does.
1, move air into and out of the alveoli ventilation. 2, diffuse gases across that membrane diffusion. 3, perfuse the lungs with blood perfusion. Everything we've talked about supports these.
It's like that orchestra analogy, every section playing its part. And it's important to distinguish ventilation, the mechanical act of breathing,
from respiration, which is the gas exchange at the cell level.
Precisely. We talk about minute volume, how much air per minute, but not all that air actually does the job. Some stays in the pipes, essentially. That's dead space ventilation. Air that doesn't reach the alveoli for exchange. And remember, the lungs get rid of a huge amount of CO2 daily, crucial for acid-base balance. But here's the key insight.
You can't just look at someone and know if they're ventilating properly.
Exactly. They might look okay, but you need tests, like an arterial blood gas, to know if they're really clearing CO2. If ventilation is inadequate, CO2 builds up, and that messes with your body's pH.
Okay, so how does the brain manage all this without us constantly thinking, breathe in, breathe out? That's the neurochemical control of ventilation. It's mostly involuntary, right? Run by the brainstem. There's a respiratory center setting the basic rhythm and adjusting it.
Yeah, the DRG, VRG, pneumotaxic center, different parts coordinating.
But the lungs send feedback too. You mentioned receptors.
3 main types: irritant receptors like smoke detectors, trigger coughs if you inhale bad stuff, stretch receptor sense lung volume, prevent overinflation, especially key in newborns, and J receptors near capillaries sense pressure increases, can cause rapid, shallow breathing.
And the nervous system can tweak airway size too.
Yep, the autonomic nervous system. Parasympathetic constricts, sympathetic dilates the airways, like fine-tuning the airflow.
Got it. What about those chemoreceptors, the chemical sensors?
Yes. Crucial. The central chemoreceptors are near the brain's respiratory center. They don't sense blood O2 or CO2 directly, but rather the pH of the cerebrospinal fluid bathing the brain.
So indirectly monitoring CO2?
Exactly. More CO2 means more acid in the fluid, which tells the brain, breathe more, blow off that CO2. They're super sensitive. But, and this is fascinating, in chronic conditions where CO2 is always high, these central receptors can kind of get used to it. They become less sensitive.
They reset.
Kind of. So the body then relies more on the peripheral chemoreceptors. These are in the neck and aorta. They do sense oxygen, specifically when it drops quite low, below about 60 millimeter Hg. And they also sense pH changes. They become the main backup drivers for breathing in those chronic situations.
Wow, a built-in backup system. Okay, let's get physical. The mechanics of breathing. Muscles, elasticity, resistance. The main muscle for quiet breathing in. The diaphragm.
Right, dome-shaped muscle. Contracts, flattens down.
Pulls the chest cavity bigger, creates negative pressure, sucks air in. And the external intercostals lift the ribs too.
Yep. Help expand the chest, side to side and front to back.
And if you need more air, like during exercise?
Then accessory muscles kick in, shoulders helping lift the chest even more. But normal breathing out,
Yeah.
that's mostly passive.
Just letting go.
Pretty much. Elastic recoil. The lungs and chest wall just spring back to their resting state, pushing air out. Unless you're forcing it, like coughing, then abdominal and internal intercostal muscles help squeeze the air out.
Okay. You mentioned surface tension before, in the alveoli.
Right. Alveolar surface tension, liquid molecules wanting to stick together, makes inflation hard. That's where surfactant comes in again. That lipoprotein lubricant from the type 2 cells.
Lowers the tension.
Dramatically.
Yeah.
Stops the alveoli collapsing on exhale, keeps them easy to reinflate, keeps fluid out. Absolutely essential. And then there's elastic properties. The lungs themselves have elastin fibers, plus that surface tension they want to shrink inwards. But the chest wall wants to spring outwards.
Okay. Opposing forces.
Exactly. And that balance creates the negative pressure in the pleural space we talked about.
Yeah.
Compliance is how stretchy things are. High compliance means easy to stretch, maybe too easy like an emphysema. Low compliance means stiff, hard to stretch, like a pneumonia or ARDS.
And resistance.
Airway resistance, how easily air flows. It's highest in the bigger pipes, nose, throat, larynx. Surprisingly low in the smaller airways because there are just so many of them. Huge total cross-sectional area.
Makes sense. And this all takes effort, right? The work of breathing.
Yep, muscular effort. If compliance is low or resistance is high, that work increases a lot. Uses more oxygen, can become exhausting, lead to inadequate ventilation eventually.
Okay. Air's in, blood's flowing. How do the gases actually move? Gas transport. It's basically oxygen from air to blood to cells, and CO2 the other way, right? 8 steps involved. A key factor is gas pressure.
The partial pressure of oxygen in the alveoli, the PaO2, depends on air pressure, humidity, how much oxygen you're breathing in.
And how well you're ventilating.
Absolutely. Higher pressure gradient means faster diffusion. Gases move from high pressure to low pressure.
Simple physics, really.
At its core, yes. Effective exchange also needs good distribution of ventilation and perfusion. V and Q need to match up reasonably well across the lung.
But gravity messes with that a bit.
It does. When you're upright, both air and blood tend to go more to the bases, the bottom parts of the lungs. More ventilation there, more perfusion there.
But not perfectly matched everywhere.
Not perfectly. For instance, way up at the apex, the top alveolar air pressure might actually be higher than capillary blood pressure, potentially squashing those capillaries and reducing blood flow. We talk about lung zones based on these pressure differences.
So we try to quantify this match.
We do. With the ventilation perfusion ratio, VQH, normally it's around 0.8, meaning perfusion, blood flow, is just slightly more than ventilation overall. The lungs manage this unevenness pretty well to maximize gas exchange.
Okay, let's focus on oxygen transport. Getting O2 to the cells. Most of it hitches a ride on hemoglobin.
That's right, about 97% binds to hemoglobin in red blood cells. Only a tiny bit dissolves in the plasma. That's what PO2 measures.
And diffusion across that alveolo-capillary membrane is super fast.
Very fast. Huge surface area, incredibly thin membrane, and a big pressure difference driving oxygen from alveoli into the blood. Hemoglobin gets saturated really quickly as blood flows past.
And that saturation, SO2, is what the finger clip measures.
Yet the pulse oximeter estimates that percentage of hemoglobin carrying oxygen. And of course, how much hemoglobin you have matters too. Less hemoglobin means less oxygen carrying capacity, even if saturation is high.
Right. Now, the binding isn't permanent, is it? Oxyhemoglobin association and dissociation.
Correct. Association is grabbing oxygen in the lungs. Dissociation is letting it go in the tissues where it's needed. The oxyhemoglobin dissociation curve shows this relationship.
It's that S shape.
Exactly. The flat top part means even if oxygen levels in the lungs drop a bit, hemoglobin stays pretty full, good for loading up. But the steep part means that in the tissues, where oxygen levels are lower, hemoglobin readily releases O2. Small drops in tissue oxygen lead to large amounts of oxygen being offloaded.
And things can shift this curve.
Absolutely. A right shift means hemoglobin lets go of oxygen more easily. Happens when tissues are working hard, more acidic blood, higher CO2, higher temperature. Think exercise. That's the Bohr effect in action, essentially.
Makes sense. Delivers more O2 where it's needed most.
Precisely. And a left shift means hemoglobin holds on tighter. Happens with alkalosis, lower CO2, lower temperature, less oxygen released. The body fine-tunes delivery based on conditions.
Amazing. Okay, last leg. Carbon dioxide transport, the return trip. CO2 is way more soluble than O2.
About 20 times more, so it diffuses super fast from tissues into blood, and from blood into alveoli, even with smaller pressure gradients.
How does it travel in the blood?
3 ways. Some dissolves in plasma, a lot is converted to bicarbonate ions, and some binds directly to hemoglobin, but at a different site than oxygen.
And there's another effect here, Haldane effect.
Yes. Kind of the flip side of Bohr. When oxygen binds to hemoglobin in the lungs, it helps kick CO2 off hemoglobin. And when oxygen leaves hemoglobin in the tissues, it makes it easier for hemoglobin to pick up CO2. It all works together beautifully.
An elegant system. Okay, let's shift gears slightly. How does aging affect all this? Geriatric considerations.
Well, several things change. The chest wall gets stiffer, less compliant. Ribs might ossify, joints stiffen. This means more muscular work is needed just to breathe.
So breathing takes more effort.
It can, yeah. And muscle strength might decrease, spine curvature can change, reducing volumes. Interestingly, the lungs themselves often become more compliant with age as elastic recoil diminishes. But this doesn't necessarily help overall function. Vital capacity tends to go down. Residual volume, the air left after breathing out, goes up.
What about gas exchange itself?
The capillary network can decrease slightly. Alveoli might enlarge a bit, reducing the overall surface area. So arterial oxygen levels, BO2, tend to gradually decline with age.
And the control systems.
The respiratory centers in the brain can become less sensitive to low oxygen or high CO2. The response might be slower or blunted. And lung immunity changes too, making older adults more susceptible to infections like pneumonia.
So overall, maybe decreased exercise tolerance.
Often, yes. But, and this is important, prior fitness level makes a huge difference. Active older adults often maintain much better pulmonary function than sedentary ones.
Right. Use it or lose it to some extent. Okay, wow. What a journey through the pulmonary system. Let's try to recap the big takeaways. We started with the structures: lungs, airways, blood vessels, the protective chest wall, pleura. We saw how conducting airways prep the air, and the gas exchange airways, especially alveoli, are where the action happens.
And the dual circulations, pulmonary for gas exchange, bronchial for tissue support. Plus that clever hypoxic vasoconstriction controlling blood flow.
Then the mechanics and control. How the brainstem, receptors, and chemoreceptors manage breathing. The muscles involved in inspiration, the passive nature of expiration usually.
And those key concepts: surfactant tackling, surface tension, compliance measuring stretchiness, resistance to airflow, all affecting the work of breathing.
Right. And finally, gas transport, pressure gradients driving diffusion, oxygen hitching a ride on hemoglobin, CO2 making its efficient return trip, that amazing oxyhemoglobin curve adapting delivery.
It really highlights the integration, doesn't it? How all these pieces have to work together perfectly, and how changes, like those with aging, can affect the whole system. It really gives you that foundation to understand when things go wrong, pathologically.
Absolutely. It's a constant unconscious marvel happening right now inside all of us. So here's where it gets really interesting as we wrap up. Think about this. Understanding these mechanisms isn't just about knowing how we breathe. It kind of illuminates the fragility, but also the incredible resilience of life itself. Maybe just observe your own breath for a moment with a bit of new appreciation for that complex symphony inside. Thank you so much for joining us on this deep dive into the pulmonary system. We really hope this has been a valuable shortcut to getting informed.
Yeah, it's truly amazing stuff when you break it down. Thanks for taking the time to learn with us today.